Look, thanks for having me here today. Look, it's a topic I'm really passionate about, and I'm sure all of you guys in your own departments are seeing patients with these big bad strokes. They're not the little perforator strokes we're talking about major vessel occlusion, and I think Graham gave a great introduction, and his images are actually better than ones in my talk, so thank you. Don't have any disclosures to make. So yeah, acute ischemic stroke, we know that 85% are due to ischemic lesions versus hemorrhagic, and CT perfusion's really changed the game, because what it's allowed us to do is look at each individual patient's physiology. Some patients have no collaterals, and after half an hour you block a middle cerebral artery, the brain behind that middle cerebral artery is completely dead. There's no point revascularising that patient. But fortunately, a large proportion of patients have very good hemispheric collaterals, and they're able to keep that brain viable for up to 24 hours or even beyond. How can we work that out? Well, prior to CT perfusion, everything was based on time-based criteria, 3 hours, then out to 4.5 hours, for thrombolysis. And what we're finding now is that we can individualise the treatment of these patients, and there's no time limitation, unlike giving lytics. So I'll move right along. If we look down the different breakdown, you can see cardiac emboli. I'll just hold it. Sorry. So cardiac emboli from atrial fibrillation is a common thing that we see, and that you guys would see, that gives a large piece of clot that breaks off and blocks off a major vessel. It's a big deal. Like you can see at the bottom, 20% of these patients are at the prime of their life. They're in their 30s, 40s, or even younger. So it's not just old patients. Big costs to the community when these patients don't go back to work and they spend the rest of their time dependent on other family members, or in prolonged rehab or extended care. It's a big deal in Australia, so we've got 50,000 a year. Every 10 minutes there's a stroke around the country. 11,000 of those turn out to be fatal. And then we've got 38,000 stroke admissions to hospital. So it's a huge economic problem. And then fortunately we now have a treatment. So when we look at that, medical management before 1996 was pretty much, like you said, get the physicians to see them, bring them into hospital, and then prepare them for rehab. After the NINS trial in 1996, we had IV TPA, which proved to be very, very useful, initially for 3 hours, then 4.5 hours. And then we had a bridging therapy in about 2000 when I was doing my fellowship, where the patients who weren't responding to the IV TPA, we were taking them and doing a thrombectomy on. And then since 2015, endovascular thrombectomy is the gold standard of treatment for major vessel occlusion. Not just after 6 hours, after half an hour we can do it. So we don't have to wait up to 6 hours to say, okay, now we can do it. We can do it with thrombolytics on board or without thrombolytics on board. It doesn't affect what we actually do. So this is what we see, and this is similar to the slides that you saw with Graham. You can see the middle cerebral artery on this patient's right carotid is completely blocked. And so there's two things we want to look at. One is the blocked vessel, the major vessel occlusion. And number two, if we look across the hemisphere there, notice how there's retrograde filling of the middle cerebral. So as I told you, there's two categories of patients. Some patients, you block off the middle cerebral and there's absolutely no collaterals. So when we get in there to do these thrombectomies, that's the first thing we see with that angiogram. We can see if they've got collateral vessels. We know about that beforehand because when they've had a CTA and a CT perfusion, we're actually seeing the collaterals, and I'll explain that in a moment. These are the studies. We were fortunate to be involved with the Melbourne group with the Extend IA. So in 2015, 5 sentinel studies came out which proved overwhelming support for endovascular treatment of large vessel occlusion. I'll move along, but the key things, if you look at the blue bars there, these are multiple different studies. This is showing the utility and the benefit of endovascular thrombectomy versus medical management, IV lytics, for major vessel occlusion. This table here, you can see the graph there to the right-hand side favours endovascular therapy. Extend IA was our trial in the middle there. Number needed to treat, 2.8 in the Dawn trial. Putting that in perspective, so for PCI, number needed to treat 29. This was an analysis done at UCLA using data from 2009 to 2015. IV lytics, 10 patients, number needed to treat. At that stage, it was 4 people with thrombectomy, so you can see the power statistically of the technique. What do we base our criteria on? It's all on imaging. So, we work really closely with you guys in ED and share the CT scanner. It really is such a major asset for multi-trauma and patients presenting with stroke. And obviously we want to rule out hemorrhage, the small 15% of patients who may present with localising neurology related to a hemorrhage. But then the second thing we want to do is find a large vessel occlusion, so CTA. And then the third thing is find out the patients who have good collateral supply, hence viable brain that's worth revascularising, and that's what CT perfusion is. One of the big problems a lot of hospitals do is they'll do the CT brain, then they'll send it back to acute, and then 2 hours later a report will come, oh, there's a hyperdense middle cerebral, we better go do a CTA. So what we do at Gold Coast and at other centres is they get all three things. There's no delay. Means you're going to do CTAs and CTPs on more people than you need to, but it also means that you're not going to miss that 25-year-old female who, historically 10 years ago we had someone who, exact scenario, they thought it was a drug overdose, she was drowsy, and she had a large MCA occlusion, which was just totally untreatable by the time it was diagnosed. So cerebral perfusion, and you've all heard about it, a lot of people fear it. It really isn't very difficult, and as I said and illustrated, it's really about the collateral supply. There's two terms, core, which is the brain that's dead, and we see that it has zero perfusion on the CT, versus the penumbra, which is the collateral supply. So again, just reminding you, that's what we're looking at. We're looking at those large retrograde vessels which are supplying that hemisphere. The hemisphere is still dysfunctional. The blood supply and the metabolic demands are not being met. But like we know from the Dawn trial, out to 24 hours, some of these patients can be effectively revascularised. And these are the colour maps we get. And again, they look really confusing. They give us lots of different information, but mean transit times, cerebral blood flow. I just like the simple red and green, which summarises dead brain versus viable brain or penumbra. But the key thing is CBV, the cerebral blood volume, that tells us that the iodine we're injecting intravenously is actually somehow making it to that territory. Okay, it's delayed. The mean transit time to that hemisphere on the left is significantly delayed. The cerebral blood flow to that middle cerebral territory is significantly delayed, but the cerebral blood volume is being maintained, and that's because of the collaterals. And you can see deep in the basal ganglia, hence the red area, that's the area that's core infarction in this patient with an MCA infarct. So we've had all these different tools over the years. Trevo is the latest, but you can see, when I did my fellowship, lots of balloons and little catheters, which really didn't work, and it was really a desperate measure to try and revascularise these patients who didn't do well with IV lytics. And the goal was just to revascularise. The brain's sort of unique because all the vessels are on the surface of the brain, so you really need a device that's aggressive enough to grab the clot, which may be thrombosed or calcified, but not too aggressive that it tears a hole in the blood vessel. Unlike the coronary arteries, or if we're doing an embolectomy in a renal artery or down the legs, they're covered by a lot of muscle. This is a little cartoon, just illustrates the point. So this is like Graham's case, is a left middle cerebral artery. So we navigate up really gently with a microcatheter. And then we bring the Trevo device up through the catheter. And it's a pullback technique. And as you can see there, it's like a stent, and it kind of splints the artery open. And as you saw in the cartoon, you actually do get some flow around that clot. So you're actually revascularising before you pull the clot out. And the next thing is, and it always comes out this easily in one piece. So, and look, the goal for us is first pass recanalisation, and that's all the different techniques that we use now is to get it in the first go. It doesn't always happen. It can take 2, 3, 10 goes sometimes when it's really large volume of clot, but the goal is first pass recanalisation rapidly. So just a couple of cases. So this is a middle cerebral artery occlusion. Similar to the others you've seen, just reminding ourselves about the collaterals. You can see here, really good collaterals distal to that occlusion, so we know that hemisphere is worth saving. That's the CT perfusion, and now you can see the cerebral blood volume is the top right-hand corner. You can see it's relatively symmetrical, so that's a really good sign. All the others are just telling us that that hemisphere is threatened because of delayed flow due to the blockage, and then that's the sort of clot that we pull out from that. It's a sort of a team effort, so this is kind of when Graham brings the patients over to us, it's all hands on deck, rapid intubation under general anaesthesia, We've got all our nurses and radiographers, and it's a head radiographer. We're always happy to be on call 24/7. There's our anaesthetists who are really important, and you know, they're stressful parts at the beginning and the end, but I don't know what he's ordering wine, I think, so trying to deal with the stress. And then industry are really important, so you know, we do a lot of research and try and get the latest equipment off the different companies, mainly based in the States, to do what we do. The room's amazing, great technology. So we've got a similar room at Pindara here on the coast and Gold Coast. There's services in Brisbane as well at the PA and Royal, and many in Sydney, Newcastle, all around the country. So a couple of cases to finish. Carotid terminus occlusion. So you can see on the left non-con CT a hyperdense blood vessel. So that's the hyperdense clot at the carotid terminus. The CTA shows a filling defect right at that carotid terminus. The CT perfusion shows us this delayed perfusion of that hemisphere on the left-hand side, and then there's that colour map that we looked at earlier, showing the green is viable brain but threatened, the red is core, so we want a small core. We don't want to reperfuse a whole dead hemisphere that's just going to bleed and be ineffective. We want to reperfuse viable brain. This is what it looks like on angiogram, so you can see carotid artery coming right up to a filling defect right at the terminus there, which you know, it looks really grim. And then we come up with our devices and remove the clot in first pass. This is another case just to illustrate a difference. 74-year-old, only 4 hours, dense left hemiparesis, not a lot of change on the non-con CT, but we do the CT perfusion, and this is just to illustrate, look at every picture, they all look the same. And then, so then I go straight to the cerebral blood volume, which is the bottom left, and I can see there's no iodine getting to that brain, even on the delayed scan. So I know that's non-viable brain. There's no collaterals there. So these are the ones we don't treat. And then sure enough, the next day, these are the people who have that appearance, you know, that horrible MCA. The good thing is, most of the people that we treat would have ended up like this if we didn't have CT perfusion and we didn't revascularize them. You know, that's a disabling stroke in a young person. Look at the mass effect. It may be fatal. They may need a decompressive craniectomy. Or, you know, like Graham said, their life may be not worth living. They're so disabled afterwards. So this is the person with no collaterals. But like I said, this used to be the regular occurrence that we'd see with these patients. This guy, tax agent, so we debated whether to treat him. This was at the old Gold Coast Hospital. He'd been to Dreamworld the day before, so poor old Dreamworld gets blamed for everything. He'd been on lots of rides and collapsed down at Australia Fair Shopping Centre, brought into ED. And the guys there were amazing because, you know, within 30 minutes of arriving, we'd had the CT, and it showed a hyperdense basilar artery. So look in front of the brainstem there, really dense basilar artery as compared to the middle cerebrals bilaterally. Obviously, the hematocrit of a patient can make their blood look denser, but when you've got that asymmetry and it fits with the presentation, this is a key thing you don't want to miss with a basilar artery occlusion. So CTA confirmed that. So if there's any doubt, CTA is so important, and like I said, we do them on all these patients with significant neurology. This is like the case that Graham showed from Pindara, a completely occluded basilar artery. So you've got the two vertebrals coming up, absolutely no flow in the basilar, so he was GCS3. He had an occluded vertebral artery due to a stenosis, and then this is us navigating through it. So this is like about 45 minutes after presentation that we're in there. It looks pretty grim, there's not much blood supply there, but this is the stent being deployed. And you can see the stent, the markers at the top of the basilar, and now you can see we've got reperfusion there. But on the side view, actually, sorry, the side view is not there, but this is pulling it out and completely recanalized, just with one retraction of the device, and that's what it looks like. And so you can see that mixed clot, which is really common. So the initial hard clot blocks it off, and then you just get progressive thrombosis behind. You can see how it's all just insinuating into the basilar perforating arteries. And anyway, we've stented the vertebral artery at the same time, as you can see there, left the that was the stenosis, so he developed in situ thrombus, so it wasn't the dissection that we thought it was from Dreamworld rides. This guy, two more cases and I'm done. 65-year-old, on the golf course, right hemiparesis, aphasic, 2 hours since onset. Again, hyperdense, so if we look at the arteries, we can see the middle cerebral artery on the left-hand side, hyperdense, fits in with his aphasia and his presentation. CT perfusion here. Again, like I said, you can see lots of missing areas, but let's go to cerebral blood volume. Pretty symmetric, so I know that hemisphere is being perfused. There's iodine getting to that brain behind the occlusion, so I know there's collaterals there. As we move along, CT-A shows us the occluded vessel, so it fits the criteria. We've got a major vessel occlusion and viable brain. So these are the ones, no matter how long it is, half an hour, 24 hours, these are the ones we can do something about. This is what it looks like with the MCA branch occlusion. You can see the clot, so we're injecting via the microcatheter, see the filling defect there, so then we deploy the device like you saw on the cartoon earlier. This is just a lateral view showing it opening, and this is literally what we see in the room. And then this is it pulling back. And then we use a little aspiration catheter, which we get right up into the brain as well, to aspirate the clot as well. And that's him afterwards, so that's him. Now this is a finishing case, a really common thing. How often do we see this? Long-term AF, warfarinized, they've come in for a urological procedure, a TURP, it's been ceased, the warfarin, day 2 post-op, they have a CVA. So traditionally, these are the patients in hospital, stroke, they can't have any lytics because they've had surgery. They're the ones who go to the nursing home or make no improvement. So we can do this. We don't need to use any lytic drugs. It's all mechanical, it's all aspiration. So look, his carotid is completely occluded. It is just full of clot. And then this is us just coming up, aspirating the clot, progressively recanalizing. Look at all that clot distally. Now we're starting to see the middle cerebral artery. So he had a good CT perfusion, and that's before and after. So very rapidly we can open and revascularize these guys. And then like Graham said, these chronic AFs, look, that's just solid clot. You could pour TPA on that and it wouldn't dissolve it. So there's no other way to get it out than to pull it out. So look, it's all about time. It's not time-based decision making anymore. It's not like 3 hours, 4.5 hours, or it's less than 6 hours or more than 6. We can't do anything. It's all about each individual patient's physiology. However, once we've determined major vessel occlusion and viable brain, it's game on. It's all fast, fast, fast. It's like Graham said, get the ambulance, get them to a centre where this can be treated. If we look around the country, just to reiterate, these are the centres or cities around the country where we have the service. North Queensland is a really noticeable absence, so hopefully in the next few years we can get something happening in Townsville. But Melbourne are really leading the way, and you can see Melbourne, their state is great. It's a really shallow state, so anyone from sort of central or northern Victoria can get to Melbourne really quickly, whereas Queensland, we're so elongated, it's really difficult to get people down from Townsville or Mount Isa. Mackay. Victoria, like I said, they've got some great integrated stroke service, and we're sort of emulating a lot of that here in Queensland, and I know New South Wales and Perth as well, doing a great thing. Melbourne have this CT in the ambulance, which is a kind of cool idea, but the way I think about it, on the Gold Coast, if you were having a stroke at Coolangatta, but this ambulance was up at Runaway Bay, it's not much help here, and you're better off just getting straight to a centre. So, this is a bit of a trial that they're doing there. It seems quite good. It's useful for giving lytics, because you can just do a quick non-con CT, make sure there's no hemorrhage, and give lytics. The other thing is, if we look at a lot of the screening tools now, everything is about trying to predict major vessel occlusion. So this is what the ambulance guys are using in Queensland. You've got the Melbourne Ambulance Stroke Screen Score. In Perth, you would have heard of the RACE score. So this is an app that they can use, and they can just dial in different presentations. And as you can see at the bottom, RACE score of 6 points, roughly sensitivity of 72% for large vessel occlusion. So all the clinical parameters are pushing to try and find these patients with large vessel occlusion, and these are the patients, like I said, we want to treat. Graham's gone into Dawn. I'll just point out the key thing here was really this slide here. So you can see Trevo, and then MM is medical management. The 90-day modified Rankin score of 0 to 2, so 0 is normal, 2 is you've got a little bit of disability, but you're independent. So of these patients, so this is out to 24 hours, half of them with thrombectomy were back to normal or nearly normal. Only 13% with medical management. So again, it just shows you, and that's that number needed to treat of only 2.8. This is us waiting for the next case at Gold Coast, sitting there doing an aneurysm. And then one of the other little things we do now is we watch flight radar. So this is Westpac 4 chopper. So while we're doing a case, so instead of ringing Lismore every 20 minutes saying, have they left yet, have they left yet, have they left yet, we're able to actually watch, and so we can see it come in. And, you know, the rooms are really heavily utilised, so we're able to finish the case we're doing while we watch Westpac 4 come in and land on the roof at GCUH. Last thing I want to show you, this is really important for everybody involved right along the supply chain, is to sort of give these feedback. So what we're trying to do now is a lot of our cases, this is from a patient from Lismore Hospital. You know, we've got a snapshot of the CT perfusion, the angio pre-post, the MRI. So we're doing an MRI on everybody after treatment just to show what the final deficit was. And then the other thing really important is just the time points, so we can see where the choke points are. Is there any hold up to, you know, or delays which we need to address along the way? Just more of the same. This patient just presented at Gold Coast Hospital. So yeah, our ED guys at Gold Coast are amazing, and you know, just get the patients straight through to imaging. Same thing. So look, this is the final slide. So major vessel occlusion, as I've illustrated. Small volume of infarct. We want, you know, less than 70 grams, so it's quite small. Out to 24 hours, we like even smaller, less than 50 grams. We want viable brain parenchyma. We've got no way of knowing unless we do a CT perfusion. And then time limits, there really isn't a time limit. So we've done plenty out to 24 hours. I reckon you could even go beyond 24 hours. The study, the Trevo study, was only to 24 hours, but these wake-up strokes are now able to be treated effectively. You know, it really is a team effort, and you know, CT has really revolutionised it. And for us, major vessel occlusion, it's pretty simple really. Major vessel occlusion, we want to recanalise it, get reperfusion into patients who are you know, acceptable physiologically. So thank you very much.
We've got time for a question whilst Hal is still here, yes?
Yep.
I probably speak for most of us in the room when I say we don't have quick access to an IR suite, and we're often left dealing with these patients for extended periods in the emergency room, and then later on told, we should probably bring them up. So that whole time as brain thing weighs heavily on what we're able to do. So in your opinion, what is the role, if any, of an MRI up front? Because that's something where I work you can actually get pretty quickly. And what role would there be for serial NIHS stroke scales, or just other creative things that we can sort of kind of give a better clinical picture to you guys downstream, I guess?
Yeah, so it's a really good question. You know, many centres, well, fortunately, most centres in Queensland have CT perfusion now. So CT, if you don't have CT perfusion, CTA is really good. And so, you know, I think as Graham has learnt, images are everything. And, you know, some patients who present with very minor neurology may actually have extremely good collaterals but have a major vessel occlusion. So it's until you do the imaging, you don't know. MR is a really good modality to look at these patients, but often they're really unstable. They're not protecting their airway very well. They might have just eaten an hour before, and you're just throwing them in a tunnel for 20 minutes. And that's really the advantage of CT for us. And so really, I think, you know, whatever the hospital is, if you can get that advanced imaging really rapidly, absolutely, yeah. If you can get a non-con CT, CTA and CT perfusion, and like I said, we've learned over the years that there's unacceptable delays, sort of splitting those three things up, and if we're wanting to find these people with large vessel occlusion and viable brain rapidly, we need to do all that imaging together. Now, these aren't just patients just with a little facial droop. These are patients with really hard neurology, dense left or right hemiparesis, you know, really firm neurology that's localising to one side of the brain with a suspected large vessel occlusion. So I think that's, for us, the best test. Yeah.
Just wanted your opinion on patients with a major vessel occlusion in that first 4 hours, where they'd be eligible for lysis or clot retrieval. Yeah, what's the evidence, or what's your feeling on clot retrieval alone versus lysis followed by clot retrieval?
So that's an excellent question. So like I said, I don't mind if they've had lysis or not. So even though we're doing an arterial puncture, and you know, we're always taught, if they've had lysis, you can't do arterial punctures. We do that all the time. So a patient who's had lysis is no contraindication to us doing what we do. What we know is that if it's a major vessel occlusion and the clot's longer than 8 millimetres, there was a Lancet study 5 years ago or more, it showed that the likelihood of recanalisation with thrombolytics alone was really low. And so these are the patients. There are current studies going on at the moment where when we did the Extend IA, all the patients that we did endovascular treatment had lytics because we couldn't randomise them to no lytics. So we had to go accepted standard of practice, which was to give thrombolysis. And these are all people less than 6 hours. So they got thrombolytics, and then some of them were randomised also to endovascular treatment. And the ones who got randomised to endovascular treatment as well were the ones who did really, really well. And that was the power of all those studies. So there's current studies now that are being done where they're saying, you know what, let's do them or randomise them without any lytics. It's a really good question because there's sometimes if they've had lytics, you're up there and you're pulling the clot out and it fragments. And I think the lytic softens it up, and then you're worrying about now little bits of clot that would normally have stuck to that device and pull out, holus in one piece, embolizing now to the distal territories, and that's a nightmare because you don't really go all the way out there to go get them. So you certainly notice anecdotally that happens, but then there's other times they've had lytics and you pull it out and it just comes out beautifully. So, I think there's studies at the moment, and it's a very current question. So I think at this stage, if they're eligible for thrombolytics, we recommend to give it because that's accepted medical practice. However, we know the evidence for endovascular treatment is actually stronger than that for thrombolytics in patients out to 24 hours when they're appropriately selected. Yeah.
So just, bit of a weird one. It's a patient follow-up question. Were any of you, anyone here, involved in a bloke who was on an A380 from LA was rerouted to Brisbane at the start of October? Not involved in that at all? Doesn't ring any bells?
No. It might have gone to the Brisbane guys,
Yeah.
PA or Raw Bris, yeah.
Okay. Just
And like I said, in Brisbane, they run a great service up there. Yeah.
I think you answered my first question.
Yep.
That's as to how distal you can actually access clots.
Yep.
And I guess the answer was it's quite difficult, but can you just elaborate on how distal you can access?
Yeah, so excellent question about how distal can we go out. And look, we've got big devices for getting clot out of the ICA, so more proximal, slightly smaller ones for the MCA, the M1 segment, and then as you go to each sequential branch, it's called M2, M3, M4, M5. M5, you're right out on the cortex of the brain. So we can go out to M3. We don't like doing it because they're smaller, they're more tortuous, it's a long way up, and then when you're pulling, it's straightening all the vessels, so there's a risk of causing a little bit of subarachnoid hemorrhage, and we do see that from time to time, but generally it's a rule of decreasing gains. When there's a little clot in a small distal branch, there's a smaller territory of brain being involved, and then us going up there to revascularise that doesn't give as much gain and poses the patient at more risk, as opposed to if there's a proximal M1 or posterior division of the M2, which is supplying the motor strip. They're the ones we go for every time. But yeah, look, we can go out to M3, but there's a lot of debate in our current field on how far you should actually push it, and then how old. Like, in a teenager, you might really throw everything at it and chase an M3 and M4 if it's going up to the motor strip. Whereas a 90-year-old, we tend to leave them because we know the vessels are much more friable and more tortuous. So.
Just quickly, thanks for that. What if they have a retrievable clot lesion, but it's a small amount of infarct hemorrhage? Would you still proceed, or would you?
Yeah, we can. So sometimes, and a really good question. You get a blocked vessel, and then you get a little bit of really subtle subarachnoid hemorrhage around it, which may not be due to vessel breakdown. You might get a little bit of diapedesis of blood that just leaks out from that damaged tissue. I think as long as the core volume is small, like I said, 70 grams, and the CT perfusion, the algorithm will calculate that. So they'll say, the core is 25 grams and the penumbra is 166 grams. They're the ones we want. As soon as we start getting to bigger core, and particularly if there is a little bit of hemorrhage, like we wouldn't touch it if it was 70 with some hemorrhage, but if it was 20 with a little bit of hemorrhage and there was a lot of threatened hemisphere, we'd take that risk. Like I said, when we do it, we don't use any thrombolytics. So in these patients, they've had nothing, no lytics, no heparin. So it is relatively safe. Yeah.
Do you think we should start bypassing from ambulance who have patients with stroke to centres with INR rather than going to ones and then have to have a secondary transfer?
I think it's a really good question about bypassing. So, like if a patient comes to a hospital, so for us on the Gold Coast, we have Robina Hospital, which is not far away. So, do we turn those patients away? I think if you can get the CT really quickly, it really helps. And it's really a physiologic triage, I always think, for these patients. So even if it's a smaller centre and you think, should we bypass? If you've got really good quality CT imaging, it makes good sense to me if you can get it done within 10, 15 minutes to then it becomes a decision point. And then it saves all the costs of transferring 20 people for one that may be, beneficial. But look, I think if they're in an ambulance and it's equidistant to a centre where you can get it, and I think that's where those, race scores and things like that are really useful. If there's a high likelihood of a major vessel occlusion in someone who's got a reasonable, life expectancy, they're the ones that we really want to get quickly. Yeah.
Thank you very much. Let's put our hands together, Hal. He's
Thank
driven
you.
down for Gold Coast to give us that talk. Thank you very much. That was excellent.